Hi, welcome to the language. Today we are going to see acute respiratory distress syndrome. In this topic, we can see what are the diagnosis protocol or clinical protocol for the diagnosis and image significance and evidence-based management. We'll see one by one. Okay, let's move. So first we'll see the definition of the symptoms. What is ARDS or acute respiratory distress syndrome? In less than 7 days, diffuse inflammatory injury occurs that lead to non-cardiogenic pulmonary edema that lead to hypoxemia and bilateral radiographic opacities. That is the symptoms definition. So clinical presentation mainly severe dyspnea, tachypnea, hypoxemia and reduced lung compliance and bilateral diffuse cracks. This is almost always similar to the pulmonary edema, but here the problem is non-cardiogenic pulmonary edema. Most of the patient lead to mechanical ventilation. Okay, so we'll see next slide. Here we are going to see what are the main causes of ARDS, or otherwise what are the etiology of acute respiratory distress syndrome. Most common cause is pneumonia. Other causes are sepsis or aspiration pneumonia, sometimes trauma or pancreatitis, sometimes massive transfusion. After transfusion that develop trali, and also the recent pandemic COVID. These are the main etiologies, or sometimes drowning. Okay, so pneumonia is the most common cause. So when you see this chest x-ray distribution is look like a bilateral diffuse infiltration affecting the multiple lung zones, mainly in the periphery. Also alveolar pattern appearing as a cloud like a puffy of opacities, usually present with the air bronchogram. So when you see this chest x-ray, typically it's a bat wing appearance, so look like a dense appearance. So it's usually in the most commonly affecting the periphery. Okay, so for the confirmation we have to do the HRCT to identify the lesion. So what are the diagnostic differentiation of ARDS versus heart failure? So both are look like a similar but different. Okay, so in ARDS usually heart size is normal, but in heart failure is look enlarged. There's a ARDS actually no pleural effusion. Heart failure pleural effusion is most common. Pulmonary edema, that means non-cardiogenic pulmonary edema, usually inflammatory edema, some most common in ARDS, but in heart failure that is hydrostatic pressure. So that means cardiogenic pulmonary edema. That means fluids are in the pulmonary. Okay, so these are the main difference between ARDS and heart failure. So when you see this HRCT chest, what will happen when the ARDS happen? So usually when you see here in this HRCT, this orange color area, this is dependent region. So here in HRCT, dependent areas of the periphery are the most common dense consolidations are occur. So most commonly affected in the periphery dense area in dependent part. So here we can see this anterior posterior gradient is classic structure appearance of ARDS lung. So in when we took this HRCT, you can see the periphery and dependent areas are most commonly affected. So how can we stage the severity of the ARDS? So in ARDS, we can stage with the Berlin definition. So in Berlin definition, we require ABG. So with ABG, PF ratio, PaO to FaO ratio with 200 to 300, that is mild. Moderate means 100 to 200 is moderate. Less than 100 is severe. So according to the Berlin criteria, we'll classify it's like this. So how can we manage this patient? So first and most important thing is treat the underlying cause. So antibiotic for pneumonia and source control for the sepsis. So we have to treat the underlying cause. And also another important thing is fluid. So we have to monitor the fluid is very important. So don't give that much of fluid. So patient should be in the hemodynamically stable. So we should avoid for the fluid overload. Another important protocol is lung protective ventilation. This is very important, lung protective ventilation. So here tidal volume is we have to maintain 4 to 6 milliliter per kilogram, and plateau pressure is less than 30, and driving pressure is less than 15. So according to the PEEP based chart, we'll adjust the ventilation. So usually the main important core is lung protective ventilation, low tidal volume. So what is the oxygen target? Saturation should be 88 to 95 and partial pressure of oxygen should maintain 55 to 80. So very important thing is here, strictly avoid high FiO2 for long duration to prevent oxygen toxicity. Okay, so we'll go to the next. So why we are using prone position ventilation? So what is the mechanism? What are the indication? So moderate to severe ARDS, PaO to FiO2 ratio is less than 150. So that indicate moderate to severe ARDS. So in this situation, we will give the more than 16 hours per day prone position. Put the patient to upside down. There's a prone position. So that lead to fluids overload, dense consolidation, and with the gravity, it's come down. So that lead to a posterior lung become recircuit and oxygen become more circulate to the lung. So that improves the mortality. So if the patient is moderate to severe ARDS, FiO2 less than 50, PF ratio is less than 150, these patients are indicated for prone position ventilation for more than 16 hours per day. So that is very, very important here. So management, what are the thing we have to do? What are the thing we should not do? So treat the underlying cause, lung protective ventilation as I mentioned above, and targets oxygen and prone position if the PF ratio is less than 150, and fluid. So fluid is very important. Don't give the excess fluid for the overload. So these are the management strategies. This is how you have to manage the ARDS patient. So what are things we have to avoid? So high tidal volume we should avoid, and also high FiO2 for long duration we should avoid. Fluid overload we must avoid, and also steroid. So why we can avoid steroid? Because steroids are no place for ARDS. So some exceptional situation like COVID. So during the COVID situation only we can use steroid. So I think now clear about the ARDS management. So this is very simple and very brief about ARDS management. So follow my channel and subscribe in the YouTube as well as in the Facebook and TikTok. Bye.